Hi, I'm Dr. Kashif Piracha. I'm a double board certified physician in internal medicine and nephrology. I'm an academic hospitalist at the Methodist Willowbrook Hospital in Houston, Texas. I'm internal medicine clerkship director for Texas A&M College of Medicine at the Methodist Willowbrook site in Houston, Texas. And I'm a fellow of American College of Physicians, American Society of Nephrology, and National Kidney Foundation. Osteoporosis has been termed a silent disease because the process in which bone loss occurs is a very long process that can actually go on for several years, even decades, and it does not produce any symptoms until the patient gets a fracture. So that's the silent part. The reason it's important to pay attention to osteoporosis is that it is a very costly disease. So according to the estimates, by 2040, the cost of taking care of patients with osteoporosis is going to reach about $95 billion. And osteoporosis, even right now, causes more hospitalizations than heart attack, strokes, or even breast cancer. On top of that, only about 20% of patients who have an osteoporotic fracture, hip fracture, receive proper secondary prevention to prevent another fracture. If you compare that with patients with cardiac disease or heart attack, almost 95% of patients get secondary prevention. So a lot needs to be done to make sure these patients are properly taken care of after their first episode. And then ultimately also have to take into account the mortality that is caused by osteoporosis. Roughly 30% of patients with osteoporosis actually die within 1 year of having an osteoporotic fracture. And that's devastating. A lot of it can be preventable if we employ the right treatment strategies. And so all of this combined has brought osteoporosis into the limelight. So it can be given the due attention that it needs to make sure that the patients are going to continue to have the best possible outcomes that we can give them. Let's talk about which patients are the best candidate for starting bisphosphonate therapy. So when I think about this group of patients, there are four important types of patients who are prime candidates for bisphosphonate therapy. The first one who are simply the patients who have osteoporosis. And how do we define that? So we do a DEXA scan at the hip or spine, and if the T-score is less than or equal to minus 2.5, that is consistent with osteoporosis. These patients are at a higher risk of having an osteoporotic fracture and should be treated with bisphosphonates. The second group of patients are the ones in which they have a fragility fracture at the hip or spine. So what exactly is a fragility fracture? So if you have a very low trauma situation that is not expected to cause fracture in somebody who otherwise has healthy bones, and that small mild trauma can cause a fracture in somebody, then at that time, there is a high concern that that is a fragility fracture and that the patient has some degree of bone loss. And these patients can be treated with bisphosphonates as well. The third group of patients are those who have osteopenia, but their FRAX 10-year risk for having an osteoporotic fracture exceeds certain thresholds. So now you have patients who have osteopenia. And how do we define these patients? These are the patients who have a T-score which is between minus 1.0 and minus 2.5 at the hip or spine. So they have osteopenia and they don't have osteoporosis. But if you have a patient like that, and that patient's FRAX 10-year risk of having an osteoporotic fracture exceeds certain thresholds, and that threshold is greater than or equal to 3% at the hip joint and greater than or equal to 20% for a major osteoporotic fracture. Now, if you have a patient like that, then that patient would also qualify for being treated with a bisphosphonate therapy to prevent an osteopenic fracture. And then the last group of patients, the fourth and last group, are the ones who are on chronic steroid therapy. So if you have a patient who's been taking prednisone 5 milligram daily, 5 milligram or more than 5 milligram daily for 3 months or greater, then that patient would also qualify to be treated with bisphosphonate for the prevention of an osteoporotic fracture, because obviously we know steroids cause bone mineral loss. So even if this patient does not have a DEXA score, which is compatible with treatment thresholds, you would still go ahead and treat them. So these are the 4 groups of patients, I think, who are the best candidates for bisphosphonate therapy. Let's talk about anabolic agents. And these drugs are new, and they have really increased our options of treating our patients more effectively. So we have 2 different types of anabolic agents. We have PTH analogs like teriparatide and abaloparatide, and we have sclerostin inhibitor, which is romosozumab. So these drugs are actually preferred to treat osteoporosis in patients who have a very high risk of having an osteoporotic fracture. So how do you define patients who have a very high risk? So patients who have a T-score which is very low, less than or equal to minus 3.0, or you may have a patient who has already had multiple fractures, or you may have a patient that is being treated with bisphosphonates and still had a fracture even on bisphosphonate therapy. Now, if you have a patient like that, that patient is a very high risk. And in that case, it is completely appropriate to start with an anabolic agent. So that's one group of patients that we can do this. Second group of patients are those on chronic steroid therapy. So patients with chronic steroid therapy may actually do better if they are treated with anabolic agents than bisphosphonates. And in fact, there is a trial in which it was found out that if you treat a patient with teriparatide as compared to alendronate, and the patient is on chronic steroid therapy, teriparatide caused a reduction in vertebral fractures, which was better than alendronate. So we do have evidence of treating these patients with the anabolic agents in preference to bisphosphonate therapy. Yes, so the key changes between the ACP recommendations from 2017 and 2023, I would highlight 3 major changes. So the first one is concerning the bisphosphonates. So obviously bisphosphonates were recommended back in 2017 as well, but now we have more data that these medications are absolutely vital. So even though they were recommended in 2017, now the ACP is strongly recommending the use of bisphosphonate as the primary drug to treat osteoporosis in postmenopausal women and also men with primary osteoporosis, even though the strength of evidence for men is a little bit lower. And then if for some reason bisphosphonates cannot be used, then we can use denosumab as the alternative for treating osteoporosis. So that's really the first major difference is the emphasis that they are placing on bisphosphonates. In 2023, the emphasis is much stronger than it was back in 2017. The second important difference between the previous guideline and the current guideline is the use of the anabolic therapies. So now, anabolic therapies, we have evidence that anabolic therapies are more potent and can give better results in patients with very high risk osteoporotic disease. And so first we have to define what it means for very high risk osteoporotic disease. These are the patients who have a very low bone mineral density, or patients in which there are multiple osteoporotic fractures, or patients who may already be on a bisphosphonate and is still having a fracture. So now we have recommendations that we can use anabolic therapies first before using bisphosphonates. And the anabolic therapies we have include teriparatide, we have romosozumab, and so we can use these anabolic therapies in very high-risk patients first, and then after they have been treated with anabolic therapies, then we can switch them to bisphosphonates. That's an important recommendation. The important point to note is that romosozumab, which is part of the recommendation now, is a new addition. The drug wasn't even around in 2017 when the last guidelines were made. The only thing that we have to be cautious about romosozumab is that it has some cardiac toxicity. So patients with heart disease, we may have to be careful how much we give them this drug. The third difference between the previous guideline and the new guideline is increased emphasis on limiting the duration of therapy patients get treated with bisphosphonates. So bisphosphonates are amazing drugs for osteoporosis, but obviously like any other drug, they have their own side effects. So now there is increased emphasis that we need to limit the use of bisphosphonates to 5 years. For a majority of patients who have a moderate risk osteoporosis, it makes sense to stop the bisphosphonate therapy and give them a drug holiday after 5 years of treatment. It has been shown that treating with bisphosphonates longer than 5 years does not give any significant additional benefit for non-vertebral fractures. It actually also increases the risk of atypical femoral fractures, and so also increases the risk of the osteonecrosis of the jaw. And therefore, it's for majority of moderate risk patients, we need to give them a drug holiday with bisphosphonates after 5 years of therapy. Now, if we have a patient who is very high risk on bisphosphonate, then in that case, we should still give them a drug holiday, but maybe the drug holiday will be shorter for them. And we need to continue to treat a little bit more aggressively than the moderate risk patients. But this increased emphasis on drug holiday from bisphosphonates is also something that is most stressed upon in the new guidelines. So a busy primary care physician, what's important for them to know about osteoporosis? So the first important thing I would mention is that don't miss the diagnosis of osteoporosis. So make sure that all patients that are appropriate for screening for osteoporosis get the screening. So any woman greater than 60, postmenopausal women greater than 65 years old, or postmenopausal women even less than 65 who have risk factors for osteoporosis. Similarly, men greater than 70 years old or men 50 to 69 who have risk factors, they all get screened for osteoporosis, so we don't miss the diagnosis. Similarly, in any patient who has a fragility fracture, they need to be evaluated and screened for osteoporosis. So that's the first important point. Don't miss the diagnosis. Secondly, just remember that for a wide majority of patients, bisphosphonates are the primary drug. You treat them with bisphosphonates. You can use denosumab as an alternative to bisphosphonate. And then if you have a select group of patients that are at a very high risk for an osteoporotic fracture, you can even go directly to an anabolic agent like teriparatide. The third important point is about the drug holiday that I already mentioned. Remember, bisphosphonates 3 to 5 years. Remember, teriparatide is 2 years, PTH analogs, and romosozumab is 12 months. So make sure the patients don't exceed the duration of therapy that has been recommended. And lastly, what's most important for primary care physicians is to make sure that they stay updated on the latest happenings in the field of osteoporosis. And the best way to do that is to continue to read about it, continue to take the CME courses, make sure that if any new guidelines are introduced, they read about it. Make sure that CME can be taken in any shape or form. If they like audio CME, there's audio CME for osteoporosis. If they like video CME, there are video lectures on osteoporosis. If they want to read about it, there are journal articles. But what's most important is this field is rapidly evolving. We've already seen significant change between the previous guidelines and the new guidelines. There are going to continue to be more changes in the future. So we want to make sure there are no practice gaps. The skills of the primary care physician continue to remain up to date. So just making sure that all proper CME is taken and they continue to read about it to make sure that if there are any new changes, then they can incorporate those changes in their practice to make sure that their patients have the best outcome.